Good evening, everyone. Today we're going to start cases of emergency medicine or emergency cases, things that may need you to activate the advanced trauma life support protocol or ACLS guidelines or use massive transfusion guidelines. In all cases, if you get an emergency medicine or emergency case, for example, you get a trauma in your Nicoski stations, or you get someone with an intracranial hemorrhage or someone suspected of stroke, they want you to make sure that you know what to do and what takes priority. In emergency cases, the most important thing is the patient stable or not? And how we know patient is stable or not? We know it through ABCs, airway, breathing, circulation. These take priority. If you are given a station with, let's say, someone who has chest pain or someone who has trouble breathing, make sure you look at their vitals and interpret the vitals uh, to their clinical presentation and quickly intervene or do or verbalize what intervention you're going to do. For example, you're going to start a patient whose oxygen saturation is low on oxygen mask. Um, someone who has trauma and has a pneumothorax, your priority would be to make sure they do not go into cardiac arrest. You would want to resolve the tension pneumothorax into an open pneumothorax. Someone who has um, abdominal injury or someone who has another life-threatening injury, your priority would be your ABCs. So airway, let's how you determine airway quickly. If patient is talking to you, it means their upper airway is open. Once you determine airway is open, you can then talk or you can then listen for breath sounds. That will be your breathing. Do you hear any breath sounds? Does the patient have any issues with any positive findings on their auscultation of the chest or heart and lungs? Once you determine breathing is fine, then you move on to circulation. How you determine if there is an issue with the circulation, you look at their vital signs, blood pressure, and pulse rate. Now, remember, in shock or in cases where someone is rapidly losing blood pressure initially stays normal or above the cutoff of 90 or 60, but their pulse goes really high initially, and then blood pressure goes down later on. So make sure that you're able to interpret someone's one abnormal finding towards what's going to happen and adjust your treatment plan accordingly. For Nicoski stations, you may not get such a serious station. However, it's possible that they give you some thing that requires urgent treatment or emergent treatment, and they want you to know what the next step is. Once the patient is, if the patient is deteriorating, what you would do. If the patient becomes stabilized with your initial intervention, what you would do next. For example, let's say someone comes in with polytrauma or trauma or road traffic accident, and what would your priority be? First thing, when you see someone who has trauma, you're going to use ATLS guidelines or ATLS protocols. ATLS protocols start with ABCs. Check their airway. Is there any bleeding or any foreign bodies in the mouth? Do they have a missing tooth? If they're talking, it's reassuring. It means that they're able to take air in. So airway, upper airways are open. Follow that up with breathing. Are they breathing normally? Is there any deviation of the trachea? Tracheal deviation will give us an idea of if there is any tension pneumothorax or a massive hemorrhorax developing on one side of the chest, or if there is a new lung collapse like a simple pneumothorax. This will be determined by the position of trachea. Look at the jugular venous distension. Once you do this, look at their blood pressure. Is their blood pressure normal? And do they have tachycardia? Initially, tachycardia may compensate for hemorrhagic losses, but as the losses become significant, they would have a drop in blood pressure and they will become unstable. So, uh, in all cases, patients with trauma, for example, they will get two large bore IVs. If you cannot access IVs on two attempts, and then you can try an intraosseous or IO access. After initial ABC, then you go to D, look for if there is any drugs involved, if the patient, another D would be your dextrose water or glucose. Then you follow it up with E. E is exposure. For trauma patients, you have to expose them from head to toe. Make sure there are no hidden traumas or hidden injuries that are missed because their patient is wearing clothes. After you expose the patient, then you can move to F, which would be fluids or other interventions that you do. Uh, remember, for trauma patients or patients who are emergent, the first priority again would be your A, airway, B, breathing, C, circulation, A, B, C takes precedence or everything else. If you get a trauma case in the history, they have history taking involved in it, and you suspect patient is become deteriorating, you can skip over history, you can go straight to ABCs. Check their airway, check their breathing, check their circulation or blood pressure, etc. If you receive a trauma case or if you are suspecting someone has polytrauma in your neck stations, make sure you have their vitals. If you don't have their vitals, you can ask the examiner what are patient's vitals, and they will explain or they will verbalize their vitals, and you can judge on that, or you can, based on that, you can take your next steps. For example, let's say you receive a patient with trauma and patient's saturation is low. This means that there is something ongoing with their breathing. If patient is talking to you while their saturation is low, it means upper airway is fine. Look at their trachea. Is the trachea deviated? Yes or no? Listen to their lungs. Are the lungs clear? This way, you're not missing any life-threatening injuries or any life-threatening conditions before you wait for your further steps. Once again, if there is an issue with ABC, address that first in emergencies, then you can do your other interventions or other assessments, etc. ABC will take precedence over everything else. I hope this helps. Now, we will have a few cases of emergency medicine or cases that you may come across in emergency rooms. They may be something from gynecology, something from general surgery, something from thoracic surgery, some cases from cardiology, etc. These are all going to be cases of emergency or ER or something that you can expect to see in the ER, since after Makowski and MCCQ E1, you're expected to start your residency, and in your residency you may be covering the emergency room, so they want to make sure that you are ready for an emergency room and you can manage common emergencies if you do come across them. I hope this helps. Let's start cases.